Hi, everyone. Welcome back for our final session of today's forum. I'm Dr. Jamie Benham. I am an assistant professor in the Department of Medicine and Community Health Sciences at the Cummings School of Medicine and principal investigator of the Embrace Women's Health Research Lab. This closing session reframes menopause not as a private inconvenience, but as a public health issue with far-reaching implications for health, productivity, and equity. We'll hear 3 short presentations from my esteemed colleagues, each bringing a unique perspective, followed by a question and answer session. All questions will be held until the end of the presentations, but you can submit them anytime through Slido by following the QR code at your table. So I will start with our first presenter. So our first presenter is Dr. Rebecca Manion, a second-year fellow in urogynecology and female pelvic medicine and pelvic floor reconstruction. Dr. Manion will explore the clinical and health impacts of menopause, including osteoporosis, cardiovascular disease, cognitive decline, and the unique challenges faced by cancer survivors. She will also clarify misconceptions around menopausal hormone therapy and discuss evidence-based approaches to management. Please welcome Dr. Manion.
Hi, good afternoon, everyone. I'm Rebecca Manion. I'm one of the urogynecology fellows and menopause practitioners here in Calgary. I just have a couple disclosures before we get started. So I am a speaker for Astellas. I also just want to note that in this presentation there is some gendered language, but this isn't meant to be exclusionary to gender diverse people who can also be affected by what's traditionally referred to as women's health issues. I know this is a bit busy, but I do briefly want to touch on some of the menstrual physiology because it's important for understanding menopause. So cyclic menstruation is the result of hormonal communication between areas of the brain called the hypothalamus and pituitary and the reproductive organs, the ovaries and the uterine lining. The brain secretes a couple of hormones, namely called FSH and LH, that signal to the ovary to mature a crop of follicles which contain eggs every month, and also signals to the ovaries to make the hormones estrogen and progesterone. These 2 hormones then negatively feed back to the brain to actually inhibit the production of FSH and LH. And I'm simplifying things a little bit here for the sake of time, but the fact that these 4 hormones work in these negative and sometimes positive feedback loops is what causes the cyclic nature of menstruation every month. Now, the average age of menopause in North America is about 51 to 52. And menopause occurs because people with ovaries are born with all of the eggs they'll ever have. So unlike testicles, which continue to produce new sperm, ovaries will eventually run out of eggs. And what this means is that larger and larger amounts of those brain hormones, FSH and LH, are needed to stimulate an ever-declining follicle pool in the ovaries. And the amount of estrogen that the ovaries then secrete sometimes isn't sufficient to actually feed back to the brain. And so you can see here in this chart, the numbers don't matter, but essentially in the premenopausal period, these 4 hormones cycle really nicely in a predictable pattern. During perimenopause, it requires higher levels of brain stimulation of that FSH to get a response from the ovaries. And sometimes the ovaries might be so resistant to this brain stimulation that you skip a cycle or 2 and then have a very heavy period thereafter. The result is that hormones during this time period can be a bit unpredictable. And this is why we always need to be really wary of practitioners or tests that claim that they can diagnose someone based on a single blood test, because depending on where that person is in their cycle, you might erroneously diagnose them as menopausal or completely normal, and why we always need to put the blood work in the context of where someone is in their cycle. In menopause, the ovaries have essentially run out of follicles, so that brain will forever be sending high levels of FSH, trying to get a response from those ovaries, but no significant estrogen or progesterone is produced. Now, most people are pretty familiar with estrogen and progesterone's effect on the female reproductive organs, but the truth is that we have estrogen receptors all over our body, and I just want to briefly touch on 3 areas. So the brain actually contains estrogen receptors, and that hypothalamus, the area of the brain that signals to the ovaries, actually also sends neurons to another area of the brain called the median preoptic nucleus, or the MPN, which is the thermostat of the brain. And this is why those hot flashes, those vasomotor symptoms, are so common during the menopause transition. We also know that brain fog is a common symptom in perimenopause and menopause. There have been a few small studies that show that hormonal supplementation can improve cognition and brain fog immediately following menopause. But whether this actually translates to a long-term improvement in cognition or declines in dementia is unclear. We do know, however, that starting hormones later in life, over the age of about 65, is actually harmful and can have a detrimental effect on cognition and dementia. The heart also contains estrogen receptors, and we know that when initiated early in the menopause transition, estrogen is actually cardioprotective. And this is part of the reason we think why women tend to have lower heart disease rates than men up until about age 60 to 65, where we start to catch up. However, this same thing doesn't hold true for women who initiate hormone therapy after about that age of 60 to 65. So we know that there's a critical timing window of when these therapies are actually effective and protective. And then lastly, we have bones. And so our bones constantly undergo a process of remodeling where old bone is removed, new bone is built. But during the menopause transition, there's a huge decrease in bone density by about 10 to 12% over 3 to 5 years, and about 0.5% per year thereafter. And so while low bone density in and of itself isn't inherently problematic, it puts you at risk of fragility and hip fractures, which are 3 times more common in women than men, and have very, very poor outcomes. Of note, the FDA in the US does list estrogen therapy as a possible preventative strategy for osteoporosis, but not a treatment once osteoporosis is already established. And in Canada, it hasn't yet been approved for that specific indication. And so the Women's Health Initiative was and still is actually the largest randomized control trial on hormone therapy we have to date. They randomized about 27,000 women aged 50 to 79 to receive hormone therapy or placebo and followed them. Of note, about 70% of these participants were over the age of 60. This study was actually stopped early due to concerns about adverse events in the hormone group. So this study is about at least 20 years old at this point. So per 10,000 women, the hormone group actually had 7 additional cardiac events, 8 strokes, and 8 additional cases of breast cancer compared to placebo. And so it was concluded that the risks outweighed the benefits. But now we actually have a much better understanding of when we break down and risk stratify people by age and comorbidities, we get much more reassuring results. So even just restricting that initial study to people under 60 changed those results dramatically, and the risks were way lower. And so the updated position from the Menopause Society is that hormone therapy is safe and effective to initiate for those under 60 without contraindications. I know I'm running out of time, but I just briefly want to talk about menopause and cancer survivors. Because people who've survived hormone-sensitive cancers like breast cancer typically cannot receive hormone therapy, but they're also doubly affected by the fact that they are at increased risk of chronic diseases that can be helped by some of these hormones. There are non-hormonal options that exist for these people, and including new therapies with good efficacy, and local vaginal estrogens are still safe in this population because they're not absorbed systemically. In summary, menopause is associated with significant shift in health risk profile. Hormone therapy can mitigate some, but not all of these risks. And postmenopausal women should be screened and counseled for menopause and midlife-related diseases and morbidity, and offered therapy when applicable. Thank you very much.
Thank you, Rebecca. It's so great to start off by grounding the conversation in the clinical realities of menopause and the health implications. And next, I'd like you all to join me in welcoming back Dr. Amity Quinn, who is a health economist and assistant professor in the Departments of Obstetrics and Gynecology and Community Health Sciences at the University of Calgary. Dr. Quinn's talk will focus on the economic and equity dimensions of menopause. Please welcome Dr. Quinn.
Thanks, Jamie. I'm really excited I got to be here twice today at this awesome event. And today I want to talk to you about midlife women at work from a feminist perspective, though I'm a little nervous to talk in front of Alana because I'm sort of new to embracing feminist theory here. But as I've been studying menopause, and I always have to explain do I have a sex and gender component of the study, I get so confused about how to answer that question because this is a biological event, but the way we're perceiving it and it's perceived is so much more complex than that. So that's kind of the generation of my thinking here. So again, menopause is this complex time where individuals' perceptions of themselves as a woman, as a partner, as mothers, as workers is being influenced by culture. Culture influences the holidays we celebrate. It influences the popularity of pumpkin spice lattes. It influences our experiences at work. And it influences our perceptions of health and disease, how we experience pain, how we seek help, the types of treatment patients prefer, and the types of treatment clinicians provide. So menopause, thinking from this framing, it's not only a biological experience of females. Menopause is, we can think of as gendered aging. Women are othered for being women, for getting older, for displaying womanness that they have tried to hide for their whole lives. Women are othered for seeking or not seeking evidence-based medical care. And I chose this picture because I thought older women bringing a cake to a party kind of similarly illustrated the patriarchy's expectations of us. I also chose this picture because I wanted to make sure we were also thinking about women's intersecting identities that are also coming into play during this time of life, such as race, ethnicity, disabilities, other health conditions that they might have. So when women are going through menopause, perimenopause at work, what does this look like? Aging women are a growing share of the workforce. Professional demands can exacerbate symptoms. Stresses of work could make you even hotter. For women's bodies at this time, I read an interesting article that talked about women having leaky bodies. So we're sweating, we're gushing blood. Again, we're trying to hide this and manage this when we're at work. As Rebecca mentioned, vasomotor symptoms like hot flashes are reported by 80% of midlife females. Yet the effects of menopause on work outcomes remain underexamined in Canada. And if we think about the impacts of or experiences of women at work, workplace supports and accommodations could be pivotal in mitigating adverse menopause experiences and enhancing women's quality of life. So while we do know in Canada, there's estimates that it costs about a little over $1 billion annually in lost work productivity. There also are individual costs of menopause. So while there isn't work on this in Canada, there's a number of studies that are coming out from Scandinavian countries that are showing that a strong association between women menopause and lost workplace earnings and income from work. So one study found women who were experiencing menopause and sought care for it earned about 10% less 4 years later. And you can see this is a figure, I think, actually from a different paper, but this figure, I think, very clearly illustrates, so the point right where the lines are going down is when you have menopause. But in these recent studies, this research is indicating that women who use hormone therapy actually don't experience the same menopause penalty. So while menopause hormone therapy can prevent women from experiencing earning loss, access to this medication remains challenging. So Rebecca mentioned the Women's Health Initiative. So you can see in these graphs, like where they're high, that was before the Women's Health Initiative. And at that point, about 40% of women were using menopause hormone therapy. When the Menopause Initiative, Women's Health Initiative came out, it dropped dramatically down. You can see that drop here, I think, and this drop has really persisted. And one thing we can see in this figure B is race and ethnicity. So even prior to the Women's Health Initiative, white females use menopause hormone therapy at higher rates than other racial and ethnic groups, and this pattern has continued to persist. And these slides are from the United States, but we see similar things in Canada. So currently in Canada, 9.5% of women report currently using menopause hormone therapy. And factors associated with lower chances of receiving menopause hormone therapy are being non-white. That is the term they used in this paper, so I'm using here non-white, currently being employed, and being obese. So I found that, while here we're seeing you're less likely to get MHT if you're employed, but using MHT can help you not have these bad work outcomes. So I'm very interested in learning more about this area. And then this other graph here shows results from preliminary work I'm doing here that indicate the prescription MHT use in Alberta. So we can see, can't go back to before the Women's Health Initiative, but it increased from a low of around 6% in 2008 up to about 15% in 2015, and that it's just stayed there. So to me, that's indicating some kind of persistent undertreatment of menopause. And then, so the effect of the Women's Health Initiative is not only on prescriptions. I know there's a lot going on in this slide, but then this is results of a study I've been doing to categorize and understand like the supply and demand of women's health services in Alberta. So I know there's a lot going on here, but if we can just focus on this kind of bright blue, and you can see that there's dramatic decrease in the blue, right? So it's high. The blue is menopause care, and it's pretty high in both. Sorry, I can't show you what I'm pointing at here, so I'm really struggling to explain this. But we can see that before the Women's Health Initiative came out, there was a lot more going to the doctor to ask for visits for menopause, and then after that, there was a decline. So there's this, there's just this lasting impact of that study on women seeking care, and then clinicians being equipped to provide care for these women. So in quick summary, menopause is a health and economic equity issue. Cultural and medical systems shape women's experiences, and workplace support could be crucial to reduce the impact of menopause on women's economic outcomes. Thank you.
Thank you, Amity, for providing that context around how policy can have an impact on menopause throughout for women in general. And I will turn now to our final speaker, who is Dr. Nicole Culos-Reed, Professor of Health and Exercise Physiology in the Faculty of Kinesiology, Research Excellence Chair and Adjunct Professor in Oncology at the Cummings School of Medicine. She is also the director of the Health and Wellness Lab and the Thrive Center. Dr. Culos-Reed will share insights from the Momentum study, a kinesiology-led initiative exploring menopause through an equity and inclusivity lens with a focus on Indigenous and South Asian women and cancer survivors. Her presentation will demonstrate how inclusive community-driven research can improve both participation and outcomes. Please join me in welcoming Dr. Culos-Reed.
So I think this is one of the actual themes I've seen come out of today, and just the interest in the room, and that's that the time is now. The time is now for a focus on women's reproductive health, and as part of that, the time is now for this focus on how do we start to address menopause as a critical aspect of supporting women's health. And so I'm here to tell you today just a few short slides around this initiative called Momentum. This is really a project that was born not out of my research as a women's health researcher. I am a woman researcher. My actual research has not ever been in women's health specifically. I'm a health behavior change researcher. But a quick story is I'm a woman going through perimenopause, and to borrow Alana's term, perpetually in perimenopause. It's just never ending, and it seemed to have started years ago. And so as I was going through this, as a researcher, I wanted to know, where's the evidence? Where can I find what I can be doing to control this, right? To empower myself, to live as well as possible? And the answer was there was almost nothing, okay? There's a lot on social media. So depending on which age group you sit in here, you are inundated with information, misinformation. 90% of it, 99% of it. It's telling you buy a weighted vest. It's telling you to don't buy a weighted vest. Please no one buy a weighted vest. If you've got one, great, but don't. It's telling you to do all sorts of things, and sometimes it comes from a trusted source, and then they're selling you a supplement. And then they're telling you to do 50 things before you wake up in the morning, right? Get your sun, get your exercise, meditate, journal. Oh my God, if I did all that, I would never leave my house. I don't know, right? So there's just so much coming at us, and that was really the impetus for Momentum. Then I was very fortunate to have an amazing group of junior researchers in the faculty who are women's health researchers. Dr. Lee Gable, Dr. Cindy Barha, Dr. Raylene Reimer. We've got newer researchers. We've got Tish Doyle-Baker, who's in the room, who's studied menstrual cycle for years. We had this opportunity to bring people together to be bigger than the sum, and that's really what Momentum is about. It's to advance the scientific understanding, not in a small bit, by leaps and bounds, and really change the discourse of how we think about wellness across the menopause journey, and ultimately empower women. That's the whole goal of this. So we started this study, and I have to cross out the join because the study's full. We had such enormous uptake, and that really reinforced that the time is now. So you can see the criteria here. We're really looking at wellness across the menopause experience. It's a cohort study. We had 5,000 women within the first week express interest to be in the study. We had 2,500 women sign up in the first 24 hours. So we will get 3,000 women through this cohort in year one, which wraps up this December, and we will immediately start sharing what we know at baseline across all these different groups. Comprehensive measures, patient-reported outcomes, questionnaires up the yin-yang, interviews, which is such a rich data source, hearing these women's stories, looking at intersectionality, comprehensive fitness assessments, stool samples, blood samples. We've got all this expertise that is really looking at this from a very transdisciplinary lens, making this very unique and making this an opportunity. I'm going to put the invite out right now for collaboration, right? Looking at our data, taking a different lens, the health economist lens, the feminist lens, right? There's all of these opportunities with this. And then it is about bringing this research, not in 5 years, not in 10 or 15 years like many cohort studies do, but today and tomorrow to our population of interest. So a very novel way of doing this. I think an innovative in a way that more research has to really start to think about how do we move this evidence to practice. So we have a podcast, it's called Living Well with the Pause. Maybe some of you will eventually want to come on and talk to our audience, and it's really about bringing our information to the general population. So you can find that on Spotify. We have newsletters. We've developed a wellness manual that we're just at the process to go back to our community to say, is this what we want? Is this what we need? We're building partnerships. And so our next phase, I mean, we're just starting the study, so it's funny to even think that we're in a next phase, because we're not. But if we're thinking about moving this further and further into practice, it's about this inclusivity and diversity. So preliminary look at our first 5,000 women is less than 8% are self-reporting that they're part of any underserved, marginalized, racial, ethnic minority group. Okay, and out of that, I think we're less than 4% self-report as Indigenous. So there's a lot of work to do to reach women. Right now, the cohort is at the U of C. There's whole groups that are never going to want to come into this setting, don't feel comfortable in this setting, and there's English as a barrier, right? That is speaking, writing, being able to complete everything in English is one of our criteria. So we have put in a large CIHR grant. We've got some initial seed funding to do some work with our Indigenous populations and build relationships, and with our South Asian communities. We are working on using participant advisory boards, so working with our population, and that idea is brought up a number of times today as well, but working with these populations to say, how could this work? How could this understanding and building of evidence work with their populations? What's unique about their needs? And how are we going to maybe do this in different ways, right? The Indigenous pathways, and there's a lot of research at U of C to support this, but that's a whole unique way of how we can potentially build some resources to support women living well, but also learn from women are empowered as elders as they go through and become into that menopause phase in that Indigenous culture. Imagine if we looked at it that way in general, that it's an empowerment and that we come with this rich resource to pass on to our people and our culture, right? So we can learn so many different things, I think. And then it's about building the resources and programming. So Dr. Lee Gable's work in strength training, Cindy Barha and Raylene Reimer, and their intersection in gut and brain health, these unique opportunities to then build the resources around those for what are the recommendations, what can women start to do. So we have a lot of really exciting initiatives happening with this work, lots of ongoing applications for funding and outreach to community. We have 2 QR codes that you can see there for our joining our community networks or our participant networks, even if you can't come into the project, but to learn, to access the resources that are all available for free. There's no cost for any of these pieces that we're building and bringing back out into the community. So I think I'm right about at time, or going to be told I'm at time, so I will end it there. Thank you.
Thank you, Nicole, very much. That's a very impressive initial outreach to your Momentum study, and we very much look forward to hearing the results. So I invite everybody to put your questions into Slido as you have them, and we can have a bit of a discussion here. So one of the things, Nicole, that you brought up in your research and for all of us to think about is diversity in terms of being able to bring this back and address this to our communities for how we can talk about menopause and how we can provide evidence in that space. Thoughts about how we can improve the diversity in research?
Yeah, and I think this is an important issue, and it's one that's been brought up today already, and it really is about working with the communities, right? And so for us, it's these participant advisory boards, it's connecting with community organizations and resources that already exist, tapping into learned experiences. And then it is really about, for us, taking a very transdisciplinary lens at it. We can't understand it from just the biology or just the sociocultural, right? We have to really bring these pieces together and work in the communities with the communities, not asking them to be our research participants, but working with them to empower their communities for change.
Any other thoughts on how we can improve as we're looking at research?
Yeah, I think the more we include diverse communities as part of the research network, like the people that are conducting the research, the more we are able to reach out to those communities as a whole. So, knowing that, like, for example, seeing what makes up university admissions or medical school admissions, we know that Some patients express feeling more comfortable talking to a female provider, or some patients feel more seen when they're speaking to a provider of the same race or ethnic background, or who can speak their language, for example. And so the more we work on diversifying our own communities as researchers and providers, I think the more we can even just open our eyes to some of those barriers we might not even be aware of in reaching other communities.
A theme that's come up kind of throughout the day has been social media. And certainly in my practice as an endocrinologist, people bring information that they've found on social media all the time. What are our thoughts if social media has some evidence-based information and lots of information that may not be based in evidence? What do you recommend is where we can go for evidence-based care? Where can people go to get care? It's evidence-based.
Specific to menopause care, the Menopause Society, formerly referred to as NAMS, North American Menopause Society, has an awesome website with great information for the public, as well as a list of where to find a certified practitioner if that's something you want more information on. I know that's not quite as glamorous or sexy as a TikTok video, but it is a good resource. The SOGC also has an Instagram page, so does the Canadian Society for Pelvic Medicine. Again, they might not have the clickbaity videos that our algorithms want to feed to us, but those are some great resources, and it's a start.
I mean, I think there is evidence-based resources on those platforms as well, but like you mentioned, Nicole, like sometimes there's one specific person I'm thinking of who is like a physician on Instagram, always talking about menopause, but then selling you supplements on the side, and that's like very frustrating. It can be very dangerous, slippery slope. I'm working, one of my patient partners in the menopause space is a Instagram influencer who was like a former nurse and now has like over 13,000 followers, and she's like always trying so hard to provide evidence-based information, but it's a challenge when you're just flooded with so much stuff. So, and then to also respect evidence-based care is what you asked. I mean, it doesn't always, I think, have to be medical care, right? And then sometimes you go to see a clinician and they actually don't know what evidence-based care is either. So I think this is a very challenging space. So,
yes, definitely. Thank you. So for all of you, how can organizations begin to address menopause without medicalizing it or reinforcing stigma?
That's a loaded question. Do you want to start from medical?
Sure. I think, that's a great question. I'm really impressed with whoever submitted that question. So without, it's a bit challenging for me to address because I am a physician, so medicalizing things is part of my job. However, I try to frame it with patients who maybe have viewed some misinformation or thinking they automatically need blood work, that's going to improve their menopause care. I try to frame it with them as, well, do we need to do blood tests to prove someone's gone through puberty? And the answer is typically no. Sometimes yes, if abnormal things are happening, and trying to reframe it as if you've gotten to menopause, you've gone through puberty. It's something we all as adults have been through, and so it's not necessarily that there is something pathologic going on with you. This is a normal, natural process for all of us who are, fortunate to live that long. But that doesn't mean it can't have undesirable side effects. And those undesirable side effects are what we're here to talk about. And so there's also a great guideline, again, from the SOGC that does talk about some non-hormonal or non-pharmacologic therapies for dealing with things like night sweats and vasomotor symptoms. Those are typically my first go-to, but often people have tried a lot of those things by the time they're coming to see me.
And to follow up, so we kind of talked about organization, but what can workplaces do, as people are going through and transitioning, what can workplaces do to help during the time of perimenopause and menopause?
Yeah, I think there's a lot of possibilities. Like one thing is you have a maternity policy, you could have a menopause policy as well. I've been reading about another, I think, well, having not gone through menopause yet myself, like I'm familiar with breastfeeding many children, so I have gone to breast special rooms, or like a lactation room. We could have like a cool room for people going through menopause. Another thought is, considering Laura's talk, like if the Alberta government isn't going to cover contraception, like the University of Calgary could cover contraception or menopause hormone therapy, so there could be a sort of other kinds of medication coverage policies too.
Very good. This question is for Dr. Culos-Reed. The low participation among diverse communities seems to be a problem in your study. Has your team thought of tailored messaging and/or recruitment methods or recruiting among community organizations working with underserved groups?
Yes, we have. So the initial outreach for Momentum, it was actually just a couple brief media pieces one day, and then it went out that night, and then the interest came in overnight. Like we literally thought we'd have 500 people a year over 3 years. That was the initial plans for this cohort. And instead we're at 3,000 people in 1 year. And so now the work, so the original Momentum grant, and I should have acknowledged Joan Snyder funding for Excellence in Women's and Girls Research is what funded this initially. Part of the plan was always to build in that inclusivity and diversity, and it's not just with our racial ethnic minority groups, it's with neurodivergent populations, it is with our LGBTQ2SIA+, it is with all of the groups that traditionally aren't in this. So while we know we don't do women's health research writ large, we do very less in our marginalized, underserved populations. And so we have, again, we've started to build. We've just started our Indigenous pathway, and we've brought together with an Indigenous researcher a group of women who are going to inform then what does our outreach start to look like, how are we going to build this, and learn in ways that are appropriate to the culture. And then our next step is our South Asian. So we are fortunate to have a South Asian group involved with our exercise work already. And we're building a specific menopause in cancer study. And so with that piece, we will have an advisory board that can help us in outreach to that population as well. And then some of the obvious needs is translation into other languages. Right? Very rarely do we have validated questionnaires across all the languages that we need. With AI, there's possibilities for doing some of this in ways that can be practical, meaningful, and less expensive. And so we can move towards doing that sooner versus just saying that's our reason for not doing it continually and continually. So those are the pieces we'll start with, and to hopefully just keep building then the right partners to do this with so we can expand and really reach anyone who's interested in this and is experiencing this and needs the resources to help understand it so they can empower themselves. That's really the goal for Momentum.
Wonderful. There have been a number of questions coming up related to menopausal hormone therapy. And one of the things that was brought up in Dr. Schumer's talk earlier was around testosterone, and there's been lots of coverage around it in the media. So, Dr. Manion, would you be able to explain kind of the role of testosterone in the menopause transition?
Sure, I love this question. I want to first direct anyone in the audience who wants more detailed information on testosterone to an excellent paper that was published by Dr. Wendy Wolfman, I think just last month in the JOGC, reviews all the evidence around testosterone supplementation. You're right, it is a bit of a hot topic right now. Essentially, throughout our lifespan, both men and women, our testosterone levels peak around age 30, and then they sort of slowly decline after that throughout adulthood. Some women have a small spike in their 70s, but it's pretty not clinically significant. So unlike estrogen, progesterone, which undergo big shifts during the menopause transition, there isn't a massive change in testosterone production. Unless you've, say, had your ovaries surgically removed, then you will have a slightly larger shift. Right now, testosterone is approved for 2 indications in Canada, and that's hypoactive sexual desire, so low libido, as well as gender-affirming care in women. I don't know about the indications in men, I apologize. So extrapolating from that data, it looks like when people are on testosterone therapy and maintained at sort of a physiologic level, the risks are fairly low. That being said, there are some changes, increased acne, increased hair growth, sometimes some mood lability or anger irritability that have been noticed in certain studies. The other thing is that we know when people are on supraphysiologic doses of testosterone that they can have a shift in their cardiac risk profile. So I did mention that women tend to have lower rates of heart disease than men, at least up until after the menopause transition. Part of that is probably related to our different hormone profiles. And so while it's not unsafe, and I certainly have started patients on testosterone for indicated reasons, and some people who find good effect and are happy with the side effect profile can continue taking it, I don't think the evidence is quite there for us to say that this is the miracle drug that it is, and women deserve better data before they go out taking sort of experimental therapies.
Thank you.
I'm sorry, I could talk about that forever.
I appreciate it, though, because it certainly is a question that comes up a lot. Amity, you had talked in your presentation about a little bit from the practitioner side of things, and there's a question here about how is menopause embedded in medical education curriculum? Is there a gap? And I was wondering what your thoughts are on this.
I don't know how it actually is. I think there's not a lot. My understanding from the research I am aware of, like post Women's Health Initiative, there has not been as much interest and it has not been included. So there's kind of this ongoing lack of information and education around menopause and menopause treatment. But I don't know, Rebecca, what did you learn in medical school on this topic?
Not enough to sum it up, and I think that's echoed by a lot of trainees, even today in training programs across the country.
And I think, too, it's changed over time, right? And kind of, but as you said, Dr. Culos-Reed, the time is now to kind of be addressing some of these gaps that exist there. And if there are ways that we can think about, what sorts of things we would like people to know from a medical education perspective, like what gaps are we seeing that really need to be included? Does anyone have any thoughts on that?
Overall wellness. The relationship between what is physiologically happening in an individual's body and then where, beyond the pharmacological treatments and other interventions, where can women take control? Where can they exert some changes or just to live as well? I mean, we know some of the best predictors of diminishing your risk for chronic disease come from exercise, come from nutrition, come from getting your sleep, come from reducing stress, right? And so empowering women and giving them the evidence base behind that, I think, is really critical.
I agree with that, but I also think there needs to be more clarification around menopause hormone therapy itself. Thank you. I, for example, was talking recently with a very prominent neurologist, and he was like, "Oh, I do not support menopause hormone therapy because it increases the risk of stroke." And so there is a lot of evidence of that, but not. That's with older oral formulations, and now we're not recommending that. We're recommending transdermal medication. So I think this is, I think an issue I would hope mostly with primary care physicians than specialists. But these are things primary care physicians should be trained and to deal with and should be comfortable dealing with, and we don't need to just have it from what my understanding of is in the current space in Alberta, a lot of primary care, just sort of general providers are referring women to specialists when they might not need to, or referring them to primary care providers with special interests in women's health. And while I totally support there being primary care providers support like special interest in women's health, I think this is something everyone should know more about. I've heard also about like this testing your hormone levels. I loved that picture you put up. It was like, yeah, exactly. Like you cannot trust these levels. Like, so that's what I've heard multiple women lately tell me they didn't get hormones or they did get hormones because of the hormone level tests. And that is also, so anyway, we need more education. So all primary care providers should come to the event on March 6th, which I saw there's posters out. So everyone should register for that.
Wonderful. There's a few more questions kind of about using menopausal hormone therapy. So it was mentioned that it may be, it seems to be more beneficial when used early in menopause to treat symptoms. And so is this a lifelong therapy? Is there suggestions around the duration about which it should be used?
Awesome question. We kind of don't really know. A lot of women will choose to go off of therapy sort of around the time they retire. We do know that when women discontinue hormone therapy, about half of them will experience a recurrence in their hot flashes or symptoms. It may not be as severe. But we don't really know is the answer. There was a great longitudinal study from last year that actually showed that continuing hormone therapy beyond the age of 65 is safe and maybe has an all-cause mortality benefit. So we definitely can continue, but that's an individualized discussion. And also, like as someone's health changes and their risk profile changes, you may choose to discontinue or taper to keep them on the lowest dose possible that manages their symptoms.
Thank you. So with that, that's the end of our time. We didn't quite get to all of the questions, but lots of questions about menopausal hormone therapy and menopause. So thank you to our presenters for sharing your insights and to our audience for staying engaged through this full day of conversation. Today's discussion reminds us that menopause is not just a women's health issue. It's a public health and economic issue that demands collective attention, investment, and compassion. And with that, please join me in welcoming Dr. Kirsten Weiss to close today's forum.
Wow, thank you so very much to that panel. Thank you all of you in the audience today for your engagement and your interest, to the speakers for your incredible thoughts and insights. I really want to thank our partners and the planning committee, the volunteers, and the staff from the O'Brien Institute and the Sex, Gender, and Women's Health Hub for their work in putting this day together. There's a survey that we'd love for you to fill out. If you could please use your camera, take this QR code and let us know how we did, what you'd like to see more of, less of, and hopefully there'll be more of these events in the future. I am so inspired. I have learned so much today. There was such a buzz in the room. To see the room so full still at the end of a long day, I think just really speaks to the importance of this issue and the engagement of those of you in this room. What did we learn today? I took copious notes. In our first keynote, Dr. Katapan spoke about the importance of language, of using words intentionally and with thought. What does reproductive age mean? Who is included, and perhaps more importantly, who is excluded from that definition? Our first panel spoke about the importance of data, of collecting it, accessing it, of appropriate definitions, and of interoperability, of making it a priority in all areas of science and at all levels of government. Our first rapid fire presentations focused on structural but not personal vulnerability, and thank you, Lena, for that term. Women experiencing homelessness and income insecurity, newcomers and refugees, women with disabilities, they must not be forgotten. Changes and advances must be inclusive, and we must use trauma-informed and culturally safe approaches to care. Our second keynote from Dr. Schumer highlighted the importance of policy in improving access to reproductive health care. It's an investment, not a cost. That was a quote. I really liked that. And our final rapid fire presentations that we just heard from focused on menopause, not as something to hide, but as a critical part of women's health and public health. How can we empower women without medicalizing or stigmatizing menopause? I really liked that question as well. So throughout the day, we heard how we define things matters, whether it's in the language we use or the data we collect, or in many cases don't collect. We also heard about the role that myths and disinformation play in women's health, and that it can actually be viewed as a form of violence against women. I hope you leave today informed, inspired, and ignited by the work that has been done and the work that is to come. Let's keep talking. Let's not make this a one-off research day. Reach out to the O'Brien Institute and the Sex, Gender, and Women's Health Research Hub if you would like to engage further. Thank you so much for being here today.